Okay, let's bosh on through it, and then we can all maybe leave early. That would be good. Sodium disturbances. Again, I'm going to talk about both. Oh, I can't see that screen. Hypo, with an O, natremia, and hyper natremia. I'll take them in turn, but just a reminder of what it's at. I know you've just watched this, I don't need to do it very much, but a quick reminder that potassium is mainly intracellular. Normal values around 3.5 to 5.3 or 5. Different values differ in different hospitals. And sodium between 135 and 145. So that we're talking about sodium right now, and this is your daily intake. You should have about 100 millimoles in each day. And this is how things are managed. There's the intrarenal system and the extrarenal system. That's something to look up when you go home. And osmolality, this is a hard concept to get through. I always forget it, always have to look it up. But essentially, it's how concentrated your fluid is, or how much solute there is in a particular solvent. So if you're very concentrated, you're going to have a very high osmolality, and if there's a very low osmolality, then you're very dilute and there's lots of water. The difference between osmolality and osmolarity is one's to do with weight and one's to do with quantity of liquid. That's the only real difference. And there's a formula that you can use to work it out. Those of you with iPhone apps, you can do it straight away, but if you want to know the formula, it's here. So 2 times the sodium plus the potassium plus the urea plus glucose. Is that right? Yeah. And a particle added to either side of this intracellular or extracellular fluid. So if you add particles here, then fluid will be moved from the extracellular fluid to dilute this, because the body is all about homeostasis. It's trying to maintain its normal internal environment. So you make a change on one side, the body will try and even out by sending water across. Much easier to send water across because it happens via osmosis, and electrolytes are usually generally well controlled through active ion transport and everything else. That's a quick reminder. Let's go low sodium, hyponatremia. We'll take the sort of disease-based structure mixed with a bit of patient-based structure as well. It's not ideal, but it's quite hard to do this. It's a bit separate topic. So definition, oh, that's wrong, isn't it? Are we doing hypo?
Yeah.
That should be less than 135.
125.
So, yeah,
Yeah.
135. Clinical features. So in your history, you're going to maybe look for any signs that any things that may have led to the sodium going low. So you're going to look in the history about any vomiting or any diarrhea, or diuretic use can sometimes cause it. So there's a little table here that I like to use, and it's based on severity. So 130 to 135 people are usually asymptomatic. If it goes lower than that, to 125 to 130, you call that mild, really. And they might feel a bit nauseous, they may vomit, and they may be slightly disorientated. And it goes through a mild confusional state with, a very low level of sodium can be associated with seizures and coma. So it is an important diagnosis to make. Not much on examination, except that you should assess the fluid status. And this is exactly what Ed's talked about before. And you do need to get quite apt at trying to work out whether your patient's underfilled, overfilled, that kind of thing. And the key to the treatment with hyponatremia is making a diagnosis, finding out why their sodium's low, because then you can treat the cause. And the treatments are very different, in fact, complete opposites. So you need to establish 2 facts to decide where the sodium's going. And the first question you need to answer is, what's the patient's fluid status? And you're going to do that by examining them. You could do serum osmolality in the blood. That may help you. But clinical examination is what you should do first at the bedside. The second question you need to answer is, what's the urine like? So are they producing very concentrated urine, and what's the electrolyte composition of the urine? How much sodium is being lost in the urine? Is it a lot, or is it no? Is it not very much? So we're going to take each of the 3 concepts one by one, and you split it. This is the way you split hyponatremia. You think of it in terms of hypovolemic, euvolemic, which is, their fluid status is essentially normal, or are they edematous or hypervolemic? So let's take the edematous patient first. So with the edematous patient with a very low sodium, this was our first question. So the first question we've answered is, what's their patient fluid status? And remember, the second question was, what's the urine like? And the question we need to ask in an edematous patient is, what's the urinary sodium like? Are they peeing out all of the sodium or are they not? If yes, that indicates a renal problem. If you destroy part of the renal tubules, the proximal tubule can't resorb all of the sodium because that's where all the sodium gets resorbed. And if they're damaged, that can't happen. So if you've got renal failure that's caused by tubal diseases, you can't resorb the sodium, so the sodium gets peed out. And also you can't manage your fluid balance, so you get edematous. So that's why you need to check the urinary electrolytes. So that indicates a renal problem. So we've got a puffy patient with a low sodium, and if there's lots of sodium in the urine, you've got a renal problem. If not, it could be extrarenal or poor perfusion, and there's a table here to go over the two. So you losing the sodium in the renal system, then this is acute or chronic renal failure. If you're not losing it through the urine, i.e. the urine electrolyte sodium level is less than 20 millimoles, then there's an extrarenal problem. And that could be congestive cardiac failure or ascites or something like that. So you've essentially got too much fluid on board. Okay, euvolemic patient, the first question, you've answered it, they're normovolemic, that's their fluid status. The second question is, what's happening to the urine? And the question we need to ask here is, how concentrated is the urine? So if it's greater than 500, so you've got very concentrated urine, yet they're normovolemic, that's not really appropriate and suggests a syndrome of antidiuretic hormone secretion. Remember, antidiuretic hormone or vasopressin inserts aquaporins into our collecting ducts and makes us resorb water. So we're inappropriately resorbing lots of water because we've got really concentrated urine, and that's making our sodium low. So you may be euvolemic or slightly hypervolemic. So a syndrome of inappropriate ADH secretion, there usually be a cause. Lots of tumours can secrete ADH and things, so it's important to look for those. And it's not the first thing you should say when someone's hyponatremic, because there are other more common causes, but it is an important cause. If not, so the question was, what's the urine doing? And so if the urine osmolality is not greater than 500, then they've got too much water on board. And this could be iatrogenic, like post-op they've been given too much, 5% dextrose. And remember Ed said the dextrose gets metabolized by the liver, and it's essentially like just giving the patient pure water, and that can dilute the sodium concentration. Or you can see it in hypothyroidism or glucocorticoid deficiency. Or there may be other things that's decreasing the concentration of the sodium, like you've got too many lipids around or too many proteins. So, myeloma with lots of proteins flying around, or we've got dyslipidemia, hyperlipidemia, that can cause pseudo-hyponatremia. So it's not really low, just looks low because it's a concentration. There are other things diluting it. Then hypovolemic. So patients, essentially, if you've got hypovolemia and hyponatremia, the patient's salt depleted. And then you need to find out where they're losing their sodium. Are they losing it in the urine? So then you ask, what is the urine concentration of sodium? If it's above 20 millimoles, then you've got renal losses. If it's below 20 millimoles, extrarenal losses. And again, here's a nice table for us to review. So always draw things out like this, it helps you. So got renal losses because it's greater than 20. That could be diuretic excess. It could be osmotic diuresis, particularly in diabetics, or if someone's given mannitol therapeutically. Mineralocorticoid deficiency, another one, or a salt wasting nephropathy, so the kidneys are just losing the sodium for no particular reason. And if the sodium is not being lost in the urine and the urine sodium's less than 20 millimoles, you're losing it somewhere else. Where could you be losing it? You could be vomiting it up, you're pooing it out, or it could be third space losses, such as in Burns patients. So the treatments are very, very different depending on which one you've got. If you're hypovolemic, you might want to give fluids. Hypervolemic, you might want to do something else. You're certainly not going to be giving fluids. So you have to treat the underlying cause. Rapid correction is very dangerous with hyponatremia because you can cause this thing called central pontine myelinosis, where essentially the myelin sheath of the pons gets completely destroyed, and it's one of the big things you should watch out for. So don't feel overzealous when you're treating a hyponatremia. And generally with electrolytes, you'll see that people like to treat things, unless there's obviously grave danger, as in with potassium, we'll see later, people like to treat things as quickly as it took them to become disturbed. So if things have been happening slowly for a long time, don't correct it quickly, because the brain adapts, and the rest of your organs adapt to that situation. So if you've got hypovolemic hyponatremia, then you can give them fluid replacement and salt replacement. So preferably, you'd give it orally. So you ask them to drink a bit more and give them a pack of crisps or something like that. Or you can give them extra salt in their food or whatever it takes. Or you can give it intravenously, normal saline. If they're euvolemic, fluid restriction, find the cause of, if it's SIADH, and treat that. That's always treat the cause. And there are these fancy drugs called ADH receptor antagonists. An example is tolvaptan. But they're not really used widespread, and they're only things that I've read in papers and stuff. Perhaps if you go to some of the big teaching hospitals in London, they'll be using it, but I've not used it. Hypervolemic, the edematous patient with a low sodium, they've got too much fluid on board, and you need to fluid restrict them. And you might set a limit, like we're going to fluid restrict you to a litre, which is really horrible, I think, for patients. So you're not allowed to drink more than a litre, including all of your cups of teas, all of the medication we're giving you, all of that stuff. That's quite a horrible thing to do, but it's the treatment. And you can give them cautious diuretics to try and get rid of that fluid, but obviously you're going to cause more sodium loss. So that's probably the arena of specialists. And fluid restriction is the first thing that you should do before getting some senior advice. So that's it, hyponatremia, split it into three: hypo, normo, and hypervolemic. Hypernatremia, definition of that is sodium greater than 145 millimoles per litre. Causes, decreased fluid intake. Hypovolemia is not necessarily dehydration. If you think about it. Hypovolemia is saying your fluid status inside your intravascular compartment, whereas dehydration is saying your sort of overall fluid state. But dehydration is a cause of hypernatremia, probably the most common cause. And decreased fluid intake, like Ed's example of the little old lady Ethel in her one-bedroom flat who's got a UTI, a bit confused, and can't make it to the sink to get some water, that kind of thing. That may go on for some time, and she may be very dehydrated and have hypervolemia. Or she may have water loss relative to sodium loss. So she might be excreting water somehow, and that could be by increased sensible losses. And these sensible losses may be sweating. Actually, sweating's a bad example because you do lose salt when you sweat as well. But I guess a nice example would be respiratory losses, because you don't necessarily lose any salt through respiratory losses. So if you're panting away, then you could be excreting lots and lots of fluid, and you can get dehydrated, and the sodium will go up artifactually. Osmotic diuretics will get rid of your water, so glucose, and a nice example of that is when there's extra glucose around, like in a honk crisis. And diabetes insipidus, and the way you differentiate that is that in simple dehydration, the urine osmolality, you'll have very concentrated urine because the body's trying to conserve all of its water. Whereas in diabetes insipidus, inappropriately, you're going to have a low urine osmolality. You're just peeing out fluid for no good reason. That's diabetes insipidus. Clinical features, well, you'll be thirsty. The thirst mechanism, if it's working, may be active, may make you feel pretty horrible, confused. I mean, I know what I feel like when I haven't had a drink all day. And when you're a junior doctor in hospital, sometimes you go, 12 hours without having a drink? And you
Another definition of renal failure is when your patient pees less than you do.
It's horrible, isn't it? When you get to the end of the day and you say, I haven't drunk all day, and you feel terrible. You feel confused and delirious, probably. But try and take a history of any vomiting, diarrhea, poor oral intake, or any diuretic use. Examination. So again, assessing the fluid status is really important. So you're coming back to this again and again with electrolytes, and it's really important you do that. Investigations. Use our sieves and things, the UBEC special, but essentially what we're going to do here is we're going to need biochemistry, aren't we? So we're going to need various different biochemical tests of the blood and the urine. But the FBC is also interesting to note because you're going to get hema concentration. So you might get hemoglobin of 15 because they've lost loads of fluid, so it makes the concentration of hemoglobin look better. And when you really vigorously rehydrate them if they're dehydrated, the hemoglobin is going to drop and people might get scared. But it's just dilutional. But obviously make sure there's no blood loss. So look at the FBC. It's a useful guide, and you can look at the hemoglobin, the white count, and the platelets to decide if, or the packed cell volume is probably more appropriate, or hematocrit, whatever you want to call it. But essentially, we're going to want the urine tests and the blood tests. We're going to want to know the urine and serum osmolalities. We're going to want the urine electrolytes, and we're going to want the blood electrolytes, the renal function. We want to check that they're not in renal failure. So remember, hypovolemia, dehydration was a cause of acute renal failure. The most common cause. So we want to check they're not in renal failure. So they're the investigations we're going to need. Management, stop and replace. So stop the cause, correct the hypovolemia, and then we're going to replace. And we want to replace the water. And we can do it orally if they're able to drink, or if they're not able to drink, we can do it intravenously. I'll refer you back to Ed's talk about which IV fluids to give in which particular situation. But for simple dehydration, normal saline is kind of an okay choice initially, even though it contains like 150 millimoles of sodium. But it will be kind of less than your patient has on board anyway, probably. And remember that we're not trying to cause massive shifts in sodium, because that can cause a problem. So I'll refer you back to the golden principles of fluid therapy, which are 1, resuscitate the patient, 2, maintenance, and 3, replace any ongoing losses. Now you can actually calculate the water deficit using a formula. So iPhone users, get your iPhone out, and you can type all these things in. But I'll just read it out to you. So free water deficit in litres is the total body water fraction, which is 0.6 in males and 0.5 in females, times their normal weight, times the serum sodium minus the desired sodium, over the desired sodium. It's actually not that hard. We'll do it for me. So my free water deficit, if my sodium concentration was 154. Remember, it has to be 145 to be hypernatremic. So my free water deficit, because I'm a man, I'm 0.6, about 82 kilos on a very good day. Probably not today. Went to Wagamama's, didn't we? And times my actual sodium concentration minus my desired. I want it to be 140. Divide all of that by my desired, and it's around 4.9 litres. That's how much fluid, free water, I would need to take on to get me back to sodium of 140. Quite handy. And monitor things. Obviously, if they're dehydrated, you want to monitor their renal function. I've read things that say like every 12 hours, but that's ridiculous. I think at least keep an eye on it once a day, because you want to check they're not going to go into renal failure. And you want to check things aren't going too quickly. So that's sodium disturbances in a nutshell, and we'll go on to potassium.